And over the next almost 1 hour, what Laura and I hope to be able to do is to describe to you what the past 2 years for us has been like as we've looked at critical incidents using the SSIT as our primary tool. I'll be sharing my screen, so we're going through slides, so I won't be able to see if one of you has a question, but Laura and I are really comfortable with what you might consider an interruption, but we would consider participation. So feel free to blurt it out if you think it. That won't trip us up or anything like that. So here we go. Let me pull up the screen. And this title was one that when we first presented this, because our agency was going through a merger, the group that we were merging with that hadn't seen it before, one of the comments they made watching the way that the SSIT was being utilized was exactly this. This could save a life. Neither Laura nor myself have financial relationships or interest in the presentation of this material. And Laura, do you want to say a couple words about the agency?
Sure. Thank you, Scott. Thanks, Brandon. So as was mentioned before, we're the largest community-based nonprofit provider in California. We're located in 20 counties. We serve directly about probably close to 25,000 people a year, but we touch about 50,000 lives through family members and community work, prevention work, presentations, and that type of thing. We serve the full age continuum from birth. We have specialized birth to 5 services, all the way to specialized programs for older adults. We also have many specialized culturally specific and community specific programs as well for the Asian Pacific Islander population, for the Armenian community, just some examples, and Latinas. We also have a specific long-term program that focuses on that population. We also provide, in many of our programs, a full continuum of care from prevention and early intervention to kind of traditional outpatient mental health services, wellness centers, drop-in centers, all the way to intensive community case management services. But a really important part of what we do is we address and have for decades determinants of care, including housing, and we have a full continuum of housing services as well as employment services, assisting our consumers, our clients in securing employment in the community and moving forward in their journey of recovery. We also provide substance use services.
So even as you're hearing that type of description, you're seeing a continuum of risk, continuum of social determinants that also may include risk, substance use, homelessness, etc. And so as we were looking at this idea of how do we manage risk, we have to recognize that sometimes what risk means, almost by definition, is sometimes stuff goes wrong. And so looking at this idea of root cause analyses and actions, and notice the plural, analyses and actions. You've maybe heard that term before, root cause analysis, where people want to reasonably, I think, look at what is the actual root cause of what happened. And when I say reasonably, maybe I should even say reasonably 10 years ago. But in 2015, the National Patient Safety Foundation, which is now part of like Institute for Healthcare Improvement, published the root cause analyses and actions, RCA squared, in their terminology, to really be able to look at multiple causes and, most importantly, a systems focus, so that as part of a safety culture or just culture, so that we're looking at reviewing the systems, not the person. And it was with that we've, at our agency, had a few different iterations of how we review different incidents. And so about 2.5 years ago, Laura, you found yourself looking at the form that we use to guide that, and you were trying to think, should we revise it? Should we pick something new? Like, what was going through your head, and what did you see as the journey from where we were to where you wanted us to head?
So the form that I moved into a new position, the form that I inherited, one did not have the information we needed, but I had received feedback following a couple of critical incidents where the teams who were presenting to an executive team about what happened in the incident kind of left the room, not sure of what was going to happen next, which was one, what action happens after this? Two, were they in trouble? They felt like they were kind of, and they admitted that it was more internal. It wasn't the way the people in the room necessarily behaved, but they felt as though they were going in to defend themselves and defend their teams, and kind of presenting very cold, this information about the client and what had happened. And it felt extremely incomplete. And so when I approached Scott, conveniently enough, it was just very, very, it worked out perfectly. I said, "Hey, could you maybe look at this form? My team has been working on it for a while, but we're mainly just adding information to capture. And it still feels like we're missing something and that we're not." And then I also talked to him about wanting our teams, how they would feel going through the process. What would help it be productive for them? What would help them feel comfortable in really diving into the root cause and seeing exactly what happened as opposed to having a feeling or a sense that they were going into a situation where they were going to defend themselves.
And, you know, we were identifying and still do identify critical incidents as those tragedies that can include suicide or a near miss, or overdose or a near miss, or potential death of a community member at the hands of our client or near miss. These are really heavy issues. And to be able to look through them in a way that accomplished what you were talking about, Laura, that became kind of the trick. I've been familiar with the RCA squared process, but then in the October 2020 TCOM conference, I was able to get a closer look at the SSIT. And so then working with Mike and Tiffany, we were able to move it from the demographic of children to the I guess this is the demographic of hipsters. It was supposed to please look at this to say, like, from the child treatment world to the adult and child treatment world. I hope that's the visual that you remember. Um, and the other part that I want to say is when there is a critical incident like this, it impacts the team in a way that isn't just about um, what tool we use or what format we use. It's about an agreement between all of us for how we're going to approach it from the position of a safety culture. Uh, and Laura, any thoughts about like the areas where that was a smooth and easy road, or where there were bumps that you had to kind of help people smooth out?
Sure. So, um, Sh Scott and I've talked about before, the first program, it was, I believe it was a member who had passed away from suicide, and when the team came in to participate in the SSIT process, I will forever be grateful to them because none of us really knew exactly what we were getting into. They certainly didn't, and they were very transparent and very open, but
Mhm.
that was unusual, correct? So, what we ran into was the need to really share a message very broadly and then to walk the walk, that this was a safe environment to be honest
Mhm.
in and to share your thoughts, share your experiences, but also, this was not the place to be, necessarily debriefing. We have a care team that goes and meets with people, That is very separate from the SSIT. This is the opportunity for people to process their grief, process their thoughts and reactions to the incident. It's very supportive. Someone like myself would never be in one of those groups, as a, as a supervisor. So really, delineating the difference between the 2, and I think that has helped tremendously. So people have an opportunity to take care of themselves, feel heard and supported, but also it kind of, is a deep breath before they then can go into this process. We have had a couple of incidents where, someone new, and Scott will describe, there's 2 different meetings that happen. So in the executive meeting, someone coming in and kind of, their own anxiety and mistakes that they saw, sharing those right off the bat and saying, "Hey, wait a minute, we should have." So having to do coaching around that individually with people to say, "This is the approach of the SSIT." Um, we've had we haven't had a lot of that, which is really great. So we'll talk about the members in a little bit. It's kind of shocking that we haven't, but it's also making sure that people who were directly involved in the incident are not sitting in a room. And that could be, for us, it's a clinical team supervisor and their therapist and case managers and maybe a nurse and a prescriber, doctor or nurse practitioner. They are not in the same room with the people at the executive level where we're doing, really the view of systems. We They have an opportunity in a different way to share their experience in a different place to do that. That's probably safer. So they're not put on the spot in front of executives they may not know well. And again, just really trying to enhance that safety culture so that they can feel free to really look at different aspects of what happened within the incident and share their thoughts and their feedback around it.
It's that dynamic of expecting people to have trust that they can share information requires that they understand the respect that's being afforded to them. Um, because we are talking about life altering and life ending tragedies, we're talking about things that impact not just in, you know, at this point, I'll say we're talking about some really heavy stuff and we're going to talk about it in a matter of fact or procedural way, but we can never lose the idea that this stuff is terrible. And most typically, the person for whom the incident is being discussed has died. And that impacts peers of that person. If that person was in group treatment or a wellness center or in one of our housing units, that impacts employees, ones who work more directly with that client or other ones on the team. That impacts family members of the client. It impacts family members of the employees. This stuff can change careers. It can end careers. Um, and the way that we identified these incidents in just a little note back to the RCA squared process, there's kind of a 2 by 2 kind of continuum of looking at whether the incident is catastrophic or serious. And then on the other axis, looking at how often does it occur? Is it rare? Is it, frequent? And so we decided to identify it as if it's catastrophic, no matter how often it occurs, death or near miss by suicide, overdose, or homicide. And this care team that Laura was referring to is really our first step in this process. And it's not just a demonstration by the agency that we are dedicated to the resilience and health of our employees, but it's also something that is led by the person at our agency who's probably the highest combination of wisdom and compassion. And part of that wisdom was making sure that the team that's put together, and this is not just clinical employees, also those who work on the administrative side, like HR or accounting, right? It's all volunteers who get trained in psychological first aid. And their mission is to help tap into and build the resilience of our employees so that they're able to move forward. After that meeting is when our SSIT work comes in. And the real theme that we have there is, um, can the agency gain wisdom from the hard-earned wisdom of individual employees? And so I'll just take a second because at this point, I really haven't even described what the SSIT is. So the Safe Systems Improvement Tool is a guide that we use for a structured conversation. There are 4 different domains that we look in that: issues having to do with the client, issues having to do with the treatment professionals, with the team, and then with the broader community around the agency level and also outside of the agency. And for example, within the client domain, we might be talking about to what degree did sleep play a role, or did substance use disorder play a role? At the uh, provider level, we might be asking to what degree did bias enter into the picture? Some of the cognitive biases like fundamental attribution error, recency effect, halo effect. At the team uh, level, we might be asking to what degree does teamwork and coordination play a role? And in fact, that will be the domain that we do a breakout group on in almost 5 minutes. And then at the broader level, we would ask questions like, to what degree did something like the demand resource mismatch play a role? And in fact, those 3 words together may not have been ones that you've spoken before, the demand resource mismatch, but as soon as it's said out loud, you know exactly what it means. And after the care team has met with the treatment team, we then have, and now we're talking about, 2-ish weeks after the incident, we have the program level meeting where I facilitate these 5 steps. The first is maybe a 5 to 7 minute description of the incident. We then do a grounding in prep for the meeting, and the grounding is essentially a description of the SSIT, but really focused on the 4 conceptual pieces that make it special. And what it is, that the SSIT is an improvement strategy. It's designed to make these types of incidents less likely to occur in the future. It's a communication strategy, both in the way that we work toward consensus and the vocabulary that we use. It's an outcomes measure, and part of the brilliance here is that because we look at, for us, it's 25 items, we look at those same 25 items for every incident, which then allows us to aggregate over time. And I think that was part of what, Laura, you were really looking at earlier when you would say every incident was kind of looked at individually. And we might say, here's maybe the training we ought to do, or here's changes we ought to make as relates to this incident. But we didn't have any way, maybe outside of people's institutional memory of an individual's mind, how to look for trends or patterns. After that, what we do is we go through and ask each participant, of all the different thoughts you may have in your head for what we might do to improve things moving forward, what's the most important improvement recommendation you might want to pass on to the agency? And we track that. After that, we take that form that's been filled out, and that guides, well, I should say, this is kind of how people are feeling, the time to listen. After that, we take it to the agency level meeting. And Laura, I'll give a couple thought bubbles because we do essentially the same agenda. But if you could speak to maybe some of these thought bubbles, I think that people would appreciate some of the roles.
Okay. So who is included in this meeting? It's at the highest level. So myself, I attend every one of them that applies and has occurred in one of the programs I oversee. So I oversee half of the agency, and I have a partner who oversees the other half. He sometimes will attend these when they occur within my regions and my programs. We also have general counsel there, so our agency has an internal general counsel, because of our size. We also have the compliance officers there. We have people from our quality assurance team and that type, and then we also which are the people saying, you know, I'm in a room with a lot of big shots. Then we also have the program director, clinical directors who oversee the program. So they may not have been directly involved in the incident, but they were there. So some of the thoughts, as I said, I spoke to the people who are coming in from the program. Sometimes may have the thought of, oh no, I'm in this room with all these high level people. We also have our medical director there. I'm the vice president saying I feel responsible. So these meetings and these sessions through the SSIT are not pleasant. They're probably the least favorite part of my job in one way because the buck stops with me. So I will have that reaction, and I know our clinical directors do, where they will say, oh my gosh, I'm responsible for this person's death. I feel responsible for that. This was under my watch. So that's one of the reactions that happens.
Oops.
Um, I am looking and I can't, sorry, okay. So, and as I mentioned, we have our general counsel coming in. So she is seeing it, and every person on this team is viewing it from their individual lens, which is why we have so many people there. We generally end up having about 8 to 9 people there. So she's coming in from the risk and the legal perspective. And then our medical director is coming in looking from his perspective in terms of medications and really focusing a lot of times on physical health. So the prescribing, the actual mental illness and the symptoms that were occurring, the impact of sleep, substance use, and other things on that. And then also, as I said, what are the impacts of physical health? The incidents that we have reviewed have all been adults at this point in time, and so physical health for people with mental illness, they tend to have an enormous number of physical health issues as well. So everyone's coming in from their own lens, their own perspective, and that is the intention of it. Again, that's why we have such a large group in the room.
And so sometimes when you have a room full of executives, you got a lot of brain power and a lot of experience, and sometimes that means a lot of different people want to be heard. Um, and there was something you had mentioned, Laura, like at the beginning when we talk about the first step is a description of the incident, a 5 to 7 minute description, typically by the person who is representing the program. And there's something about the way that that 5 to 7 minute description isn't met with a barrage of questions or comments. What's your
Mhm.
guess for why?
It's really interesting. So, as Scott mentioned, the grounding that happens at the program level meeting, we also do a grounding and in a discussion, a reminder, no matter how many times someone has sat through an SSIT process, there's a reminder of one, um, the tool and the focus of it. But two, I did want to point this out, and Scott, you always do such an excellent job of taking a minute to acknowledge the individual who passed away or was in a terrible situation or did possibly something violent to someone else, to talk about that this is everyone's, this is a very, very difficult time, and giving respect to that before we kind of launch into the meeting. But it's interesting because um, it is pretty free form how people can provide that description of the incident. But one thing that I believe it's not met with a barrage of questions is everyone who's been through it before knows the tool. It's so comprehensive. And that's my feeling because I like to ask a lot of questions. I realized that I didn't need to do that very quickly after the very first session because my questions are going to be answered within the tool. And I think that really helps. It helps people put their agenda aside. It relieves you of the distraction of when am I going to find out this piece of information? I really want to get to the root of it. The tool takes care of that because and I think that really speaks to again, the comprehensiveness of the tool and the thoroughness of it. It is 25 items, it's not 300, and you're still able to get your questions answered every time.
And there's something about the way that we go through each of those items and reach a consensus where we're kind of starting to talk and reach a conclusion, but other people could add in and say, no, no, I maybe see it this other way. And then this process of the back and forth is one that, in fact, what we're going to do now is get ready for our breakout rooms. So I want to give you a brief vignette. And then after the vignette, don't worry, I'll get back to it in a second. We're just going to look at one of the items. And so the item that we'll be looking at in your breakout rooms, about 4 of you, is the teamwork and coordination item. And that's the question of, to what degree might there have been ineffective collaboration between 2 or more internal or external entities? We're going to focus internally for this one. So were there barriers that existed in internal communications? And of course, because really this is about kind of having a systems focus, not a person focus. In fact, back to the RCA squared idea that one of the rules of causation is human error is not a cause. Something else had to have caused that. These 4 categories are in a format those of you who are familiar with other TCOM tools will recognize, but you don't have to recognize them to say, well, let's call it this first one if we have no evidence of an issue with teamwork and coordination. Nothing to see here, right? Or one might be, maybe it was a background influence. Maybe there was no known impact to the case, but there were teamwork and coordination concerns present. A 2 is that the teamwork and coordination impacted actions or decisions that maybe impacted the safety or risk assessment. And it was not proximal to a poor outcome. I'll spend a second on this word. Proximal is kind of related to proximity, how similar in theme or content, how close in time. And then a 3 would be teamwork and coordination impacted decisions proximal to a poor outcome. I will not read aloud while you read to yourself. What we're going to do is go to the breakout rooms and spend about 7 minutes. So Brandon will pass you the PDF of these 2 slides so that you and your group, if one of you wants to share, you can go back and forth. And if you have a question, let Brandon or myself know in the chat. What you'll do in your group is try to reach consensus. Given the vignette, what do you rate teamwork and coordination? Any questions before we head to our breakout room? Welcome back from your breakout room. I hope that your team was able to have some back and forth. And oh, we haven't started. We haven't all gotten back yet.
Yeah.
Well, welcome back for being the quick people. The other ones who are ambling back, strolling back. We'll talk to them in 20 seconds.
Just imagine that they're getting more coffee.
That's what they're doing.
Their breakout rooms were farther away than ours, so we've been a longer walk. Yeah.
There we go.
Welcome back from the breakout rooms. I hope that your group was able to have some back and forth in figuring out a consensus. And I'd love to hear from maybe 3 different groups. I think there were maybe 6-ish groups. If we could hear from a representative from a few groups, what was the back and forth? And I should also add, the conclusion that you reach doesn't have to be the same conclusion that another group reached. Really, this is a communometric tool, and part of the idea is it's about communicating. So let's focus on that as the priority more so than, oh my gosh, we said it was a 2, you said a 3? Oh, who's wrong? We're not even going to go there. That's not part of our aim. So can we hear from somebody?
I'll go. We were group 11. Hopefully my audio is okay.
It's great.
We settled on, we talked about a 1 and a 2. We had some conversation about whether or not he completed suicide or he did not. We went with the assumption that he did not complete suicide. And we talked about how at the beginning of the vignette, it talked about the team collaborated well on those high intensity cases, but then this case was identified as less intensive. And after some back and forth, we landed on a 2. Just because we felt like that would have been an expected communication on the part of the psychiatrist, especially because that patient resided in a setting where it would have been important for safety planning or other things for people to be aware, maybe to put in whatever precautions were appropriate in the event that he was more serious. And, when he recanted, that statement actually was serious and might have made an attempt. So we landed on a 2.
Thank you for describing that, Tracy.
Sure.
Can we hear from another group?
Sure. It was just one person and it was a 2 group. We landed on the consensus of a 3, which I assumed was detrimental. Neither contingent on completed suicide or not, just all the red flags were there, where there was no plan, no assessment of suicide, all these different stressors that were happening for this person, including a recent loss, a move to board and care, a mom who was stressed out, his feeling of not wanting to be a burden, a statement. So there were just so many red flags that we had, and just kind of the psychiatrist not teaming at all, not talking to anyone. So we felt it was in close proximity to the outcome, regardless whether he completed suicide or not.
And something I noticed between both of your descriptions, in the first talking about the context, this is a team that does work really well together. But then in the second saying, well, in terms of how proximal is this, it's the content does fit. And yeah, this question of would it be one or the other? Let's hear from one other team and then we'll talk a little more. P.S. I'm not going to go, and here's what we ranked it, because it's really about how does your team work together. So let's hear from one more.
Well, this is Yolanda, and we were a 2-woman team as well, a 2-people team. Chelsea, I met her, she McCracklin, I think. I'm sorry if I mispronounced her name, but we went with what I call it, maybe the Pinocchio effect. Well, we know this is what it's not, but then what is it? So having to say that, we kind of processed the fact that they did work well together, but then this was a lower level case. However, for us, suicide is never lower level. So we kind of talked about the recent is what kind of stuck out with us, and kind of looking at the scoring effect if something is recent, in the Tennessee case, we will score 2. And I think Chelsea's, they'll do something similar as well. She's in North Carolina. So we kind of reasoned what it was not, and then kind of came up with the 2. And we felt like a 3 would be intense action, or it would have been more of a poor outcome if the person had attempted suicide. So it did not give us that information. So that's why we didn't land on a 3, but we kept it a 2 as something definitely that needed to be addressed. However, it was not critical or disabling because there was no evidence that he had not committed suicide or attempted to commit suicide. Chelsea, anything you want to add on that?
No, I think you covered it perfectly.
Thanks so much. And if I'm understanding, for the 2 of you, you use this tool, I'm guessing, in the child welfare system. So it's a familiar tool to you.
Yes.
Wonderful.
Yes.
I really do appreciate the way that the folks who work in child welfare, in order to have this fit for you, expanding it to look at adults in this type of situation. That's terrific to see. And I know that I was lucky enough to be able to speak with a couple of different people who worked in child welfare when we were first starting this out. I think it was a team in Oregon who met with me and walked me through it. So I have a debt of gratitude to your teams. Let me move ahead a little bit. Thank you so much for the teams that shared. This is exactly what helps us to get an understanding for what consensus is about. And then what we do after each of these meetings is we look to organize the information. So one of our programmers built us an app that allows us to enter in the client ID that then connects into our EHR. We identify the incident type, whether it's overdose, near miss, suicide, homicide, and then what was rated for each of these items, and then a brief narrative related to that rating. And we go through you saw the client domains there. These are the environment domains, the demand resource mismatch, like I mentioned before, policies, training, technology. And then what we have here at the bottom is improvement recommendations. This is a little bit different than the way that the child welfare teams do it with improvement opportunities or IOs. Here for the improvement recommendation, we don't identify a gap as much as we say, moving forward, here's what I think would be a good thing for us to do. What this allows us to do is to have from the program level, the improvement recommendations, which have been suggested by, say, a case manager, a clinician, a prescriber, a supervisor, as well as those that have been suggested by a senior vice president or a medical director. We've got those all together. And with that organization, we're then able to look across all of the items and see over a period of time that we look at. For us, it's typically annual. And I cut this graph off to not show too much. And this is not an annual time frame. But we look to see which ones tend to stick out as being more likely. And the way we have it is, and here we can see like teamwork and coordination. That's the area we were talking about. If you click here, you can then see the improvement recommendations. Laura, can you say a few words about, for you, what it's like when we do these annual meetings and you see, or even as we're putting together a meeting and you're hearing people talk about improvement recommendations, what are your thoughts about what you see from the program, what you see from the agency, and how that guides us?
The first thing that comes to mind, Scott, is how it's always interesting to me and sometimes surprising, though it shouldn't be, how there will, and you can see it here, there's not instructions to that your recommendation has to be unique, but there tend to be several unique recommendations, and then there'll be 2 or 3 people who will say, okay, I approve with, I agree with that person. Or sometimes people feel compelled to mention something different and give a unique recommendation, but they tend to fall into 3 categories for me. One is very quick fixes, low hanging fruit that we can take care of immediately. Others are recommendations that are changes in our everyday work processes that may take a minute, but can be implemented. And it's kind of a no brainer. And yes, we should have been doing this all along.
Right.
And then the third is something that requires a deeper dive. So it is, the frustration comes when I see something on the recommendations over and over again as the leader that we haven't taken care of it yet, or it's something that we haven't been able to impact and make a change on. That is a little bit painful and frustrating. And so it's, looking at why we haven't been able to make an impact there. There do tend to be consistent themes with communication and coordination, as Scott knows. I'm glad you used that one as the example. That's probably my biggest area of concern, and really working to improve that. And then you'll see recommendations that are based on things that are going in the community. And one is fentanyl.
Mhm.
And that is a massive issue in LA County. And we have had consumers who died of overdoses, accidental overdoses. And so that we'll go through a few months where there are consistencies in the incidents, and then also you'll see some consistencies around the recommendations. So.
And as you're looking at these recommendations, you can see that a couple of them sound more connected to an incident like the one that was described there. But keeping in mind, this is looking at 3 different incidents during this time frame. And so now as we're getting to some of these others, collaboration with external resources in an attempt to obtain prior records. Now we're talking about a different incident, but one that had issues with teamwork and coordination. And to your point, Laura, part of the idea about how do we put these things into action? How do we take this from, oh yeah, look at that thing that someone ought to improve, to like, how should we improve it? So what we do, and so far we've done it annually, and that's because these critical incidents don't occur often. So in order to have an aggregate, we look at where do we see the trends, what improvement recommendations are there, and then we try to identify 2 or 3 initiatives that we want to move across the agency as a project. And that's with our leadership team, so that we can consider those improvement recommendations that have been made by people at various levels throughout the agency, and then try to move that forward. Like you had mentioned, Laura, in 2020, and fentanyl hit LA kind of later than it did other parts of the East, and kind of went across the country east to west. But we didn't used to have people in our housing units die. Then all of a sudden, some did. And so we had a Narcan initiative, and that really led to distribution of training in Narcan. And so I think the other part that I really want to highlight as far as values are concerned, do you remember back I think this is pre-pandemic, but it feels like it was longer ago. Like when you used to ask someone, "Hey, how you doing?" People used to say good. But now when you go, "Hey, how you doing?" People say busy. And there's a risk in an agency for us to stay busy. And sometimes busy means that we are having a lot of meetings. When they say things like, you get someone on a remote meeting who types into the chat, "Sorry, I have to go to my next meeting." Stuff like that. But there's a real importance in taking these issues and moving them forward. And there are, this is not to say that we at Pacific Clinics move every initiative forward smoothly and effectively. We have our frustrations, absolutely. But we have to have that decision-making in the right hands. We have to be able to have these improvement recommendations all from different levels of the agency come to the front. It's not just what do the execs think we should do. That's not what makes it work. We've got to be open about it. And to the interest of those who are in risk management with the agency, how do you make it so that we aren't opening ourselves up for lawsuits? Well, when it's part of quality assurance, then it's more legally protected. Even in these annual meetings, in the most recent one, the second one we did, we had a consumer client representative. That's considered best practice, but it's not easy to put together in a way that can have us legally covered. because there's nothing worse than that really worked and we stopped doing it. You know, that's not the refrain that we want to be part of. So Laura, before we get questions from people, what closing thoughts do you have on our 2-year journey, lessons learned, and what you hope people take away?
I think sometimes when we're faced with a new form and a new process, to your point, Scott, we're all very busy, and people may be resistant to it because they're very overwhelmed and burned out. And I have not heard people ever complain or push back on the use of the tool or the sessions, because it is pretty much, I think the consensus it is the most important thing we do in our jobs. As I mentioned, they're my least favorite sessions and meetings to go to. But they're absolutely the most important. And then the ability to aggregate and get, I'm a huge proponent of getting feedback from across all levels of the agency, including as consumers or clients. It's to have it in a format, in a safe space that allows for equal voice from so many people, I think also lends a lot to the acceptance in the use of the tool, which is really wonderful.
And we have time for 1 or 2 questions. And if there are no questions, what I'll say is thank you for your time and participation. And we hope for those of you in child welfare that this continues to be an important and effective part of your work. And for those of you who are working in agencies, maybe even those that are looking toward accreditation or already have it in something like COA, which in the risk prevention and management section specifies that analysis of each critical incident is required, or whether it's JCO that looks at having corrective action plans, and JCO explicitly recommends the root cause analysis and action process, which the SSIT fits in perfectly, or whether it's CARF, the Commission on Accreditation of Rehab Facilities, for people who have, let's say, an employment division that looks at being able to have annual analysis of patterns that lead to corrective actions. I hope that you're able to maybe take this and move it forward with your team.